So today we're going to go over how we as nurses manage the surgical experience. This is termed perioperative care, and it includes pre-op, intra-op, and post-operative care. I'm splitting up our pre-op and post-operative lecture, so this one right now we'll just be covering preoperative care. So we'll go ahead and get started. So as I said, there are 3 phases of perioperative care. The first phase is the preoperative phase. This begins when the decision to have surgery is actually made. So that preoperative phase then ends once the patient is transferred to the OR for the surgical procedure to then begin. As you might imagine, the preoperative phase can vary in length. So if a person were to have, for example, joint replacement, maybe that was scheduled or planned, the preoperative phase might be quite lengthy as compared to a person who was who came into the emergency room, let's say with like a perforated appy, right? And they needed to have an emergency appendectomy. That preoperative phase might be very short. So it just kind of depends on the urgency of the surgery, the reason for the surgery, all of that kind of thing. On how long that preoperative phase how long that preoperative phase lasts, but regardless, the time period is what you see here from that decision all the way up until transfer to the OR. And then we begin the intraoperative phase, and that starts with the admission to the surgical department and lasts until they transfer to the recovery room. We're not going to spend any time really talking about intraoperative care. There are a few little things that I would like for you to know. There's a video I'll have you watch. Those things will kind of cover our need to know on intraoperative care. And then finally, our last part of the perioperative phase is the postoperative care. And that starts in the recovery room and extends until complete recovery is achieved and lasts until that follow-up appointment is completed. So again, that postoperative phase might vary in length depending on the type of procedure that the patient had, or what kind of complications perhaps they were experiencing after the procedure or whatnot. So that postoperative period can vary in length as well. Let's see what we got going on next. Okay, so different types of surgical procedures. Now, if you look at your discussion questions for preoperative care, we should cover most of the questions on there during this lecture. There are some things in this lecture that aren't necessarily on your discussion form, and I may not go in exact order, but I will definitely be sure to make sure that I have hit all of them before I click stop record on this. So urgency of surgery might be elective. That might be something that you might not think of. Actually, a lot of surgeries that we might think of as necessary or urgent may be considered elective. For example, one that comes to mind that we commonly think of is having our gallbladder taken out, also known as a cholecystectomy. Oftentimes, those are considered elective procedures, and patients will have to wait to have that procedure done. They'll just have to manage symptoms and pain and stuff like that at home. Emergency and urgent, those are kind of close in definition. Of course, one is just, if you don't go right now, you're going to die. That would be an urgent procedure. Emergency is that would be an emergency procedure. If you don't go, you're going to die. If an urgent procedure would be like, you need to have this done, but it doesn't have to be right this moment, but we're going to get you in as soon as we can. And then, of course, optional are going to be those things that, we don't really have to have surgery for it. We're just choosing to. Something that comes to mind in this category might be some type of plastic surgery, rhinoplasty or facelifts or things like that. Surgeries can also be classified based on risk, whether there's a major risk or a minor risk. And oftentimes it's this risk that determines the different locations that surgery can take place. So we can do surgery in an inpatient setting in an outpatient setting and then in an ambulatory care setting. There are lots of surgery centers that are popping up. That would be an ambulatory care type surgery, and you'd be amazed at some of the types of surgeries they can do. With the ambulatory care surgery, a patient comes in, day of surgery, they've completed all of their preoperative care as an outpatient through the provider's office and whatnot. They come in, we get them ready for surgery, they do surgery, they get done with surgery, recover them, and they go home from the ambulatory care clinic right then and there. Those are typically freestanding buildings, oftentimes not attached to a hospital or something of that nature. The patient has to be pretty stable, has to be a pretty minor type surgery. We're not going to do a CABG, in other words, in an ambulatory care clinic. And we're probably not going to, do, a joint replacement, like a shoulder surgery on a patient who has a lot of cardiac problems either. So like my husband had a rotator cuff repair, but if you're a patient who has a pretty significant medical history that puts you in a high risk category, you're probably going to have to do that in a location other than an ambulatory clinic. Outpatient surgery is most likely going to be attached to a hospital of some sort. Patients may come into the hospital, have surgery, be released the same day. That's considered to be an outpatient surgery. Another example of an outpatient surgery would be maybe they've stayed overnight. They haven't stayed, I don't know exactly what the laws are. It might be 48 hours. But once you go beyond that, you're you need to either meet inpatient criteria or leave. That's all insurance lingo. But just know that sometimes outpatient surgeries are not necessarily you leave the same day. Sometimes an outpatient surgery can technically be you stay overnight. But anyway, they're recovered in the hospital and then they're let go rather quickly. You might see a surgical unit be called like a short stay outpatient unit or a short stay observation unit or something of that nature. These patients are coming in having pretty simple surgeries, we're making sure they're okay, and then they're leaving within 24 or 48 hours. And then of course the inpatient setting is definitely in the hospital. The patient is either some kind of urgent or emergent situation, or it can even be a planned procedure, but it's pretty significant. Patient maybe has a complicated medical history, and we are going to keep them in the hospital for several days to monitor them and make sure that they are safe for discharge. So that risk kind of will dictate where a patient can actually have surgery, because we need to have access to emergency equipment and be able to transfer patients to critical units if need be. So we don't want to put those high risk patients in a freestanding ambulatory clinic if that's a possibility. As far as why a person might have surgery, there's lots of different reasons why a person can have surgery. Some of you may have even had surgery yourself. Could be to fix something. Maybe it's if you have a tumor and you completely take it out, you've had a curative surgery, you're cancer-free now. It could be to make somebody comfortable. My brother-in-law had a brain tumor that was causing problems with things like seizures and stuff like that. And so they went and they took the brain tumor out, and it didn't cure his cancer. He actually had lung cancer with mets to the brain, but the removal of that tumor made him more comfortable and allowed him to have an extension on his life. So different reasons why a patient might have surgery. Biopsies, we're diagnosing things. So that's what we're talking about when we're talking about purpose of surgical procedures there. So in the preoperative period, right, that period as we're getting the patient ready for surgery, one thing that we use in healthcare is a preoperative checklist. You really need to be making sure that that is done. The checklist is going to contain a list of all different kinds of things that you need to have ready and in place before this patient is actually ready to go to surgery. And the reason we have checklists is so that we don't forget anything. And it helps us I guess to just not forget all the stuff that we're supposed to do, because there's a crap ton of things we have to do to get someone ready for surgery. So for example, we have to make sure the patient has a medical history done. There needs to be a baseline assessment completed. If there are any type of orders for things like antibiotics or, whatever the case may be, those things need to be implemented. The patient has to have signed the consent form. Education is often done in the preoperative period. This is key because in the preoperative phase, especially those people who are having planned surgeries, that preoperative phase might be really long. Our education starts in those moments. We can teach patients about things like reducing complications, which we'll talk about in our postoperative lecture, but getting up the importance of ambulating to reduce DVTs and pneumonia, the importance of coughing and deep breathing, and using incentive spirometry to reduce the risk of atelectasis and pneumonia. So we can start teaching patients how to move, when we're expecting them to get up, oftentimes, and sometimes this is cultural also, so be aware of this. Oftentimes patients and family members think that when you have surgery, you should lay in bed. And the evidence tells us that that is not true. We want our patients getting up and moving as soon as we can after surgery, as it's safe for them, as much as they're able to, as their condition allows them to, because we know that reduces the risk of complications from the surgery and immobility and all of those kinds of things. So if we start that education in the preoperative phase, patients are already kind of primed for what to expect in the postoperative period. They're not going to be freaked out when they wake up with a tube in their nose, or, if they're asked to get up and walk the same day. Or at least if they are freaked out, they'll have had some time to kind of simmer down a little bit so that they know what is expected in that postoperative period. So the pre-op care that we'll continue to talk about here is pretty much going to be contained in your preoperative checklist. Different organizations will have different checklists, but for the most part, they're all going to contain the same things. Other things that I haven't mentioned that I'm seeing on checklists are things like giving patients CHG baths prior to surgery. I like to call it a treatment, and it's a chlorhexidine gluconate treatment. We wipe them down with CHG impregnated cloths, and it helps reduce the bacterial load on the skin. That way, when they go to surgery, they're going to clean them again, of course, but we've done that extra cleaning, so there's less of a risk for surgical site infection. Let's see, other things would be taking out their dentures, making sure they're, they don't have any jewelry on. We want to make sure all that's off to keep the patient safe. If a patient's taking a beta blocker or a type of medication that's often used for cardiac issues and hypertension, we want to make sure that they've had that medication prior to them going to surgery if it's appropriate, because it is going to lower their heart rate and their blood pressure. But for most people, we want to give that. We need to, when they last had something to eat or drink. So anyway, there's going to be a whole list of things that we are going to be doing. And we're going to talk about some of that stuff and the importance of it as we go on here. So patient history is one of the first things we're going to do. We need to look at what kind of medical problems the patient has. And this is that subjective preoperative assessment. So when we say a subjective preoperative assessment, that's data collection. We're asking the patient, do you have this? Do you have that? I want to know, do you have any cardiac issues? Do you have any history of diabetes? Do you have any history of lung disease? Have you ever been diagnosed with cancer? Have you had surgeries before? Have you ever had anesthesia before? What kind of reaction did you have to anesthesia? Did you have any complications after any surgeries you've had before? So I'm collecting all of this information from my patient so that we can identify any potential problems. If my patient, for example, has a history of COPD or chronic obstructive pulmonary disease, and I'm about to give them anesthetic that's going to depress their breathing, they might have a hard time coming up off of that ventilator in the post-operative period. So I need to know that so that the surgeons, the anesthesiologists can choose medications appropriately for the patient. If my patient has a history of, congestive heart failure, I know that they're going to have potential problem with fluid management, and I'm going to have to be kind of careful with the amount of fluid that a patient gets during surgery. So that's why we collect all of that subjective data, so that we can get an idea of what kind of potential problems our patient might have. And this all gets documented in the patient's chart somewhere. It seems now electronic medical records are the charting location of choice. So that's where we would all put all of that, so that a patient, so that anybody on the healthcare team can access that. So other things we want to know about, of course, their age. The older and younger the patient is, the more likely they are to have complications. So we need to be concerned about that. Medications are a good thing to find out about what the patient is taking, and always ask them about non-prescription medications too, because sometimes patients don't think that Tylenol or ibuprofen are actually considered medicines. So you can ask them about things that they're prescribed, but also ask them about other things, vitamins and supplements as well. So those things can sometimes interact with different things. Another thing that can have different things, meaning like anesthesia. Another thing that can happen when you ask a patient about medications is perhaps you said, do you have any history of any medical problems? And they say no. And then you say, are you on any medications? And they list like 12 different medications. Well, if they're on 12 different medications, they have some medical history. So that kind of helps you sort that out and get an idea of what kind of comprehensive issues you might be getting yourself into. There is a document that I uploaded onto Canvas. It's some kind of, I think I called it medication preoperative assessment or something like that. It's not from your book, it's actually from a different resource, but it has good information on there. I would make sure to look at that. And it talks about what you would do in the preoperative period if a patient reports taking particular types of medications. Sometimes knowing this historical information, gathering this patient data, can drive what kind of tests might need to be ordered so that we can make sure that the patient is safe for surgery. For example, let's say you have a 22-year-old married woman who is not on birth control of any type whatsoever. What test do you think is probably a priority for that patient, right? And they're married to a man. I'll just put that in there, all right? That patient, we don't want to do surgery on them if they're pregnant. So we would probably get a urine pregnancy test. So knowing that little piece of information, the age and marital status and whatnot, sexual history of a patient, helps us know what tests to do on a patient. Another thing might be a patient is on aspirin. Maybe they take aspirin and Plavix every day. They have a history of peripheral vascular and coronary artery disease. They take these two medications to help reduce the development of blood clots, platelets sticking together, so that maybe they have a stent and they don't want it to get plugged up. But that puts them at risk for bleeding. So perhaps that patient is going to need to stay off of those blood thinners, those antiplatelet medications, or for 7 to 10 days before they can even have surgery. So look at that sheet, look that sheet over. It talks about antidysrhythmic medications. It talks about anticoagulant medications, medications for hypertension, variety of different things there. Make sure you know what a positive response would then drive a nurse to look for, and what kind of test they would expect to be ordered or asked for being ordered. Something that you need to know. Allergies, important to know this, a couple of different reasons. Number one, latex. At least here in the hospital where I work, most things are not latex. And I don't work in surgery, so I can't say that 100% for sure. But we really have a big push to avoid products that contain latex. So we do need to know, however, if a patient has an allergy to latex. If they do, sometimes what will happen is that patient might be the first surgical case of the day, so that the room doesn't get contaminated, or maybe the last surgical case of the day or something like that. I don't know. They might have a special room, surgery suite set up for patients who have latex allergies. That's something like antibiotics. It's very common for patients to get prophylactic antibiotics to reduce the risk of surgical site infections. And so we need to know if they're allergic to any antibiotics. So that we can choose antibiotics appropriately if that is the case, if the doctor needs to give antibiotics. Last oral intake, we need to know about that. I don't need a daily log of what they've been eating for the last 4 days. I want to know when's the last time they had anything to eat or drink, and what was it? The reason for that is I'm trying to reduce the risk of aspiration. Now, this is going to be something that depends on the urgency of the surgery. If a patient was in a 6-car pileup crash and has to have emergency surgery, I don't really care when they ate or drank, because if they don't go to surgery, they're going to die, right? We talked about emergency surgery. But if my patient maybe is coming in with right upper quadrant abdominal pain, nausea and vomiting, and they have cholecystitis, and I'm going to take their gallbladder out, and they just had a big cheeseburger and Diet Coke an hour ago, well, they're probably going to have to wait 6 to 8 hours before they can actually go to surgery. Because it's not urgent, right? It's not an emergency situation. We're going to give them fluids, keep them NPO, control their pain and nausea. And then once it's safe for them to go to surgery, their stomach is empty, we're going to take them to surgery. Different literature will say different things, but it's usually about 6 to 8 hours. Clear liquids, if someone had a drink of water, a few hours ago, we're less likely to be overly concerned about that. But it is something that we need to know. When's the last time you had something to eat, and what was it? And when's the last time you had something to drink, and what was it? That way we can document that information. The surgeon can decide risk benefit of surgery and timing. But we do not need to know everything that they've eaten for the last 24 hours. It doesn't matter. Okay, alcohol, that's what ETOH stands for, alcohol, smoking, drug use. We do need to find out about this information in a very non-judgmental way. Sometimes that can be difficult, but in all honesty, as a nurse, getting a patient ready for surgery, while I care for you as a human being, it's not really I don't care if you drink. I don't care if you smoke. I don't care if you use drugs, because that's not why I'm asking. I do care because you're a human being, and I don't want you to harm your body and yourself. But for purposes here, the reason that I want to know is because I need to know what to anticipate. Again, remember that preoperative history collection, data collection, is so that I know what kind of complications to anticipate in the post-op period. So I want to know if you drink alcohol and how much you normally drink, because if I get you up on my floor in 2 days and you start going through withdrawal, you could have serious complications, right? I need to know that. And I can prevent those complications by getting the correct medications prescribed for you. I'm not here to make you quit drinking or to make you quit using drugs. I'm here to keep you safe while you're under my care. Same thing with smoking. I need to know if you smoke, how much you smoke, whether that be cigarettes or marijuana, which can fall under drug use as well, depending on where you're at. But I need to know that, because that's going to compromise your ability to oxygenate and ventilate, right? It's going to impair your lungs. So I need to know that. Again, I'm not going to make you quit smoking. I'm not going to let you smoke in the hospital, because, that's against policy. But I do want to keep you safe, and I do want to be prepared for your lungs not working. I don't want to worry about why you're not coming off of oxygen. At least now I have an understanding as to why, you're 38 years old and you're on 2 liters of oxygen and you're 90%. Well, you've smoked since you were 15. So it just helps to guide my care for you. Again, with drug use, a couple of things to consider with drug use. I want to know what kind of drugs you're using, because they can interact with medications that I'm giving you for anesthetic. They can also, a person can build up a tolerance to them. So if you, for example, are a heroin user, That is an opiate. And so most of the time in the post-operative period, I'm controlling pain with opioids. And if you are a heroin user, it's going to take a lot more pain medication for me to control your pain than someone who is what we call opioid naive, right? Has never had an opioid before. So, like I said, it makes no difference to me whether or not you use drugs, although I don't want you to. But more so, I need to know so I can provide care for you. I want to be able to control your pain. And if I don't have that little tidbit of information, then I can't advocate for you and get you what you need so that you can be well cared for in the post-operative period. Be careful asking about these types of questions: alcohol, smoking, drug use, also, as well as psychosocial history. Just because just always be aware of who else is in the room. You may have to ask a family member or parents to step out for questions like this, just because we want to make sure that we're getting honest answers so that we reduce the risk of harm in the post-operative period. And even people who are married, we think married people share everything, but, watch Breaking Bad, how long did Skylar go without knowing that her husband was a meth manufacturer, right? We hide things in all different types of relationships. So be careful asking these questions, be direct, be forthright, and use privacy when you're doing them, and consider who is in the room when you are asking these particular questions, because I guarantee you will likely get a different answer depending on who is actually in the room. All right, so that's a lot about subjective history. Advanced directive is another aspect that we need to be asking about. So advanced directives often refers to code status, right? It's not always just code status, but that's a big part of it. We want to know what the patient would like to happen if they were not able to make decisions for themselves. So we most commonly think of coding a patient. If your heart stops, if you stop breathing, do you want us to do chest compressions? Do you want us to intubate you? We need to have frank discussions with patients about their wishes, about their desires. Best way to do this is just to be upfront and direct. Make sure that patients understand that if they choose to be what we call a DNR, or do not resuscitate, that doesn't mean that we're not going to treat them. We are still going to take care of their problems. We are going to give them antibiotics and do surgery. Like, we can do all of these things to treat them. It's just that if their heart stops, or if they stop breathing, that we're not going to do CPR and advanced cardiac life support. Sometimes if a patient decides to be a DNR and they're going to have surgery, that DNR status may be lifted during the surgical procedure. So that might be a conversation that they need to have with the surgeon about how that works if it's something they're concerned about. Let's see, living wills are another part of this, or a durable power of attorney. Now, living will is not a document that states that, you get the dresser and Johnny gets, all my cash, and Beverly gets, the house. It's not a divvying up of stuff. A living will is a document that guides the healthcare providers on what you want to do in regards to your health. It can be very minimal and include something just as simple as nutrition and hydration. It can be very extensive, where we get into, like, if you give a mouse a cookie, right? If this, then that. If I am brain dead, then do this. But if I can't breathe, then do that. But if I have, it can get very extensive. So just different documents that are out there. Someone can designate a medical power of attorney or a healthcare representative. Those people are designated to make decisions regarding healthcare, money. Someone that controls their money and their finances and their assets, that's a different thing. But like a medical power of attorney or a healthcare representative helps them make decisions if they are unable to do it themselves. So if grandma is alert and oriented and she's just a mean old booger, and the granddaughter is the healthcare power of attorney, and she just can't wait for grandma to die because she wants all her stuff, the granddaughter can't make decisions for grandma unless grandma gets to a point where she cannot make decisions for herself. So that doesn't mean that they can do whatever they want being a healthcare representative just because there's that paperwork, there's that stipulation in there, right? If that patient is not able to speak for themselves, then they can step in and make those wishes known. So be careful who you choose as your healthcare power of attorney. I've had that happen before, where family members will say, yeah, but I'm the healthcare power of attorney, so you have to do what I say. And I have to remind them that, you know, that's not true because this person is alert and oriented. So it's something to be aware of. We always want to have this, like I said, ask somebody about it. Oftentimes this is part of an admission history, not even part of surgical care, but just in general, we're asking patients about their advanced directives. What do they want to happen? Okay, so our physical assessment. So the purpose of the physical assessment is to have a baseline assessment that we can compare our post-operative assessment to. So we want to make sure that we know how all of the systems are functioning, right? You guys have learned how to do a physical assessment in Skills Lab. So we look at all of the systems. We look at neuro, we look at the heart and the lungs, and how's the liver functioning? How's the kidneys doing? What's the skin look like? What kind of GI issues? We're looking at the whole complete head to toe assessment. Okay, because things could change. And when things change in the postoperative period, we need to know if it's normal for this person or if it is indeed something that's different and we need to be worried about it. So let's say, for example, I'm taking care of a patient and I'm doing a preoperative assessment and I listen to their heart and their heart sounds are regular. I've got S1, S2, I can hear them very clearly. I'm not auscultating any kind of abnormal heart sound and my rhythm is nice and regular. And then in the postoperative period, I listen to my patient's heart sound and I hear an irregular heart rhythm. It's beating kind of funny. And I hear a murmur, right? That's not normal for that patient, and that could indicate a electrophysiology problem or even a volume problem. So we need to have that baseline from which to compare. So you guys reach back to what you did with your physical assessment in Skills Lab, and we're going to get all of that. We always want to include height, weight in the preoperative patient because anesthesiologists will dose their medications based on body surface area, and so they need to have that accurate information in the computer so they can make those calculations. Vital signs, don't forget, we always include pain in that. This is a good time to talk about a patient's tolerable level of pain. We need to know what a patient is able to tolerate in terms of pain, because if a patient's having surgery, odds are they're going to have pain afterwards, right? That just kind of makes sense. So they need to expect that, first of all. And secondly, they need to know that they're going to get pain medication regardless of what number they assign their pain, okay? So we tell our patients to rate their pain on a scale from 0 to 10. 0 is no pain, 10 is the worst pain ever. What's tolerable for you? I don't care. Pick a number. It makes no difference to me. What matters is if you tell me that your pain is a 4, your tolerable pain level is a 4, then when I'm trying to control your pain, my goal is to get you to about a 4, okay? And if you tell me that your pain is an 8, then I give you pain medicine and your pain is better, that number should go down. Okay, if your pain is an 8 and I give you pain medication and you feel better, your number should not then be a 9. All right, so that's something sometimes we have to educate our patients on how that works, because they often will think if they don't rate their pain high enough, they're not going to get any pain medication, and that is definitely not true. We're going to treat the patient's pain however they need it to be treated. We just need to know if what we're doing is working, because if it's not working, then I'm not going to keep giving you the same thing over and over again. Maybe we need to try something different or some kind of alternate intervention to deal with pain. Okay. Let's see what we got next here. Okay, diagnostic data. So in the preoperative period, your patient's probably going to get some diagnostic data. This might include things like labs. So here you can see a list of different labs that are very commonly ordered for a patient who's having surgery. A type and screen is going to tell us what kind of blood type the patient has, and it's going to screen the blood for antibodies. So we're not necessarily going to cross-match the blood to any available units or get any of that ready, but if we needed to, we would already have that patient's blood type and be able to begin that cross-matching process. A CMP also stands for a complete metabolic panel. You might also see a group of labs called a BMP, which stands for a basic metabolic panel. They're pretty much the same thing. It's just the complete has more information in it. This is going to give us lab values to reflect things like electrolytes, renal function, some things like that. So our potassium and our sodium, BUN and creatinine, they're going to kind of tell us some information about that. PT, INR, those are labs that we get to measure how thick or thin somebody's blood is, especially in response to a drug called warfarin, also known as Coumadin. If a patient's blood is too thin, their INR is too high, outside of the therapeutic range, and they're on warfarin, they may not be safe to go to surgery at that time until we can reverse that clotting or that anticoagulant, right? A normal range for an INR for a patient who is taking an anticoagulant warfarin is about 2 to 3. If a patient has a prosthetic heart valve, if that's the reason why they're taking warfarin, it's about 2.5 to 3.5. So that's high, but for the cases of why we would have a patient on warfarin, we want it to be high because we're trying to prevent blood clots. But the higher it is, if it gets higher than that, then it puts them at risk for bleeding during surgery. Sometimes even if they are in that therapeutic range for whatever reason they're taking warfarin for, the doctor may still give them something to reverse that medication. So we can use vitamin K as a good reversal agent for warfarin, or we can give fresh frozen plasma. That also helps to reverse that INR. CBC is this complete blood count. That's going to give us information about what the different blood cells are doing. So what the hemoglobin is doing, what the white blood cells are doing, what the red blood cells are doing, what the red blood cells look like, various different things like that. We're looking for signs and symptoms of infection, signs and symptoms of anemia. If our patient comes in and they have a through the roof white blood cell count, I might be very concerned that there's some kind of underlying infection here. Or if their hemoglobin is really low, I might be concerned that they are losing blood somewhere that we can't see, and they could be at risk for problems associated with hypovolemia or hemorrhaging. So need to have that information there. Urinalysis can be done to make sure they don't have a urinary tract infection. We might do an HCG on a urine, or that's a pregnancy test. Any female that has not had a hysterectomy pretty much gets a pregnancy test or hasn't gone through menopause. So yeah, different diagnostic data that we're going to get on our patient. Anything that's abnormal, we need to understand why it's abnormal and if we're okay with it being abnormal. Is it something that we're expecting? Does this patient have renal failure? We're expecting their BUN and creatinine to be elevated. Are they going to surgery because they're losing blood, so their hemoglobin's going to be low? Whatever. But we need to understand what's going on with those different labs. Different radiology tests that you might see might include some of the things that you see here. MRI, CAT scan, ultrasound. Those are typically done to give us an idea of the underlying structures that we're getting ready to cut into or cut nearby to, so we can have an idea of what we're getting into as far as the surgeon's perspective is concerned. Chest x-rays is very common to have a chest x-ray, especially if it's a patient who has a history of lung disease. just to make sure that they have good healthy lungs before going to surgery. One other test we might do would be an EKG. Sometimes you'll see this ECG. It's an electrocardiogram is what that is. And what we're doing is we're looking at the electrophysiology of the heart. When we think about our patient's medical history, right, we've talked about that subjective data. We've talked about that objective data with our head to toe physical assessment. Our findings from that data collection might also help us to maybe prompt a provider if they haven't ordered something that perhaps they need to. So for example, if a patient is taking an antiarrhythmic, we've learned from our data collection that they're on amiodarone, and the patient hasn't had an EKG in over a year. Well, that medication directly affects the rhythm of the heart. So I might reach out to the provider and let them know, hey, would you like to get an EKG? This patient's on amiodarone. So we're kind of looking at the big picture here and taking that data that we're collecting during our history, during our physical assessment, and making sure that we have everything that we need, again, to make sure that the patient is safe to go to surgery. We're moving right along through this checklist here. Ooh, that was fun. Okay, informed consent is something that is obtained by the provider. A nurse's duty and role in an informed consent is to witness the signature on that consent form. We can also supplement the education or reinforce the education that the provider has provided, but a true informed consent, a real informed consent, the doctor, the surgeon should come talk to the patient, describe the procedure, any alternative things that they could do or something instead of the procedure, what is actually happening, what's to be expected after surgery, what they can expect during surgery. They need to know about the surgeon themselves and the person that's performing the procedure, what kind of risks are involved in the surgery, what their rehabilitation is going to look like, how long they're going to be in the hospital, what their recovery at home is going to look like, what their follow-up is going to look like, what restrictions are going to be placed on them. They need to know everything about this procedure for them to be able to make an informed decision. It's always important to remember that a patient can refuse treatment at any time, or they can change their mind. They can say, you know what, I don't want this procedure. I'm not going to do that. They have that right. It's just at that point, it's a matter of communicating, right? We want to make sure that we communicate with the provider if that happens. It's also the duty of the nurse to make sure that the patient understands the procedure, not to educate them about the procedure. That's the provider's job. That's them obtaining informed consent. But if we go in and our patient is here with gallbladder disease and they're going to have a cholecystectomy, and we go in and we're trying to get a signature on our informed consent document, and we're telling them, please explain the procedure to me as you understand it. And they say, well, they're going to go in my mouth and down into my stomach, and then they're going to cut my gallbladder out and pull it out through my stomach. Well, that is not what a cholecystectomy is, right? So clearly the patient does not understand the procedure. So in that instance, you would want to, if that's really what the patient thinks is going to happen, you need to get a hold of the provider and say, hey, this person does not understand what's going on. I know you've educated the patient, but they do not get it. You need to come back up here and you need to educate them. Also, you want to make sure that the patient has received informed consent before they sign the consent form. If you have an order to get a consent form signed and you take it in there and the surgeon or the doctor hasn't even been in there, you need to not get that signed, right? Because they need to have an explanation of what is going to be done to them, what they can expect, this whole informed consent procedure before they actually sign that. There have been multiple times where I have sent a patient to surgery, called down to OR and said, hey, the doctor has not been up here. They have not talked to the patient. They have not explained to them what they're going to do. They have not signed the consent. A couple of things can happen. In that instance, the surgeon then might come up and talk to the patient, and then I'm totally happy to get the consent form signed and be a witness to that. Or I have also had them tell me, go ahead and send the patient down. We'll talk to them when they get down here. That's fine, or whatever, but my concern about that is, what if you get them all the way down there and they decide they don't want the procedure, which I have had happen before? It becomes a frustration on everybody's end because they've gotten a room ready, they're wanting to go, the surgeons, the healthcare people, and then the patient gets down there, they get the procedure explained to them, and they're like, nope, no thanks, I'm not doing it, and they have that right. So it's the best thing to do is for the surgeon is to get up there and explain the procedure to the patient before they even put an order in for an informed consent. So it is the provider's responsibility to obtain an informed consent, and the nurse can reinforce education, be a witness to a signature, that kind of thing. Okay. So yeah, just a reminder, obtained by the surgeon, done before any pain medications, right? Especially for a planned procedure, because pain medications can be mind altering. So the patient really needs to be in the right state of mind. That can be a little bit tricky, so just be careful. You need to make sure that you feel comfortable signing that consent form, that the patient really does understand what is happening to them. The pre-op nurse can identify educational deficit and witness the signing of the form. So good couple of reminders there. All right, what is a timeout? Well, a timeout is kind of like our rights for surgery. You guys may have talked a little bit about our 5 or 6 rights or whatever we have for medications. We have the same type of verbiage when we talk about a timeout. It's also called universal protocol. And the whole purpose of the timeout is to make sure that everything is correct. We have the right patient, we're doing the right procedure, we're operating on the right side, like the correct side. The correct surgeon is in place. We have all of the right equipment in the OR ready to go. We have the right documentation as far as lab work and imaging. All of those things are in place. Timeouts will be done multiple times throughout that preoperative period all the way into the intraoperative phase. A patient will be sent for to be brought down to surgery, and you'll see the surgery techs often come up and get them, a tech that'll work down in the OR. They'll transport them from the patient's room down to the OR. And they will ask them, can you tell me your name and your birthday? Can you tell me what procedure you're having? Can you tell me what side you're having this procedure on? Can you tell me who your doctor is? So they're verifying that everything matches. Timeout is done again in the OR with the surgical team. They're verifying that they have the right patient, the right surgery, that it's marked, all that kind of stuff. When my son had surgery on his arm, he was asked about 4 different times which arm, right, they were going to be performing surgery on, and he had to tell them every single time. We don't want to perform a wrong site operation. That would be devastating. You've probably heard things like that in the news, and we definitely don't want to be part of that. If at any time you're doing a timeout or performing this universal protocol and something doesn't match, you need to stop and go back to the beginning. Do you have the right patient, right? Do you have the right chart? Have you come to pick up bed B and you're standing by bed A, right? And maybe they're both having surgery. You got to go back and start all over. You have to do your due diligence. What if you come and get your patient and they're having a right BKA and the consent form says left BKA? Are you going to argue with them and tell them no, but your consent form doesn't match the procedure? No, we start all over at the beginning, and this could require a new consent form getting filled out, a new informed consent even taking place. Maybe the doctor needs to come and clarify things. We don't assume that patients are confused or that they don't know what they're talking about. We stop, right, like a timeout indicates. We go back to the beginning, make sure that everything is right before we continue. And if something's not right, we fix it. Patient teaching, I alluded a little bit to this earlier in the lecture, but we'll go over it more here. Teaching will help reduce the anxiety that a patient's feeling about having surgery. If you've ever had surgery before, or a family member maybe has had surgery, you know that it can make you very anxious. You're scared, you're worried, you don't know what's going to happen. Oftentimes surgeries are performed because there's some sort of problem that can be very scary. So if we teach the patients, it gives them a sense of control. They know what to expect. They know how they're going to handle the post-operative period. Families should definitely be included in any patient education, because once they're discharged from the hospital setting, it's family that's going to be taking care of the patient. So they are very important in teaching for operative care. We might even start going over discharge information, what you have to do to be able to be discharged from the hospital, the criteria that you need to meet before you're even discharged from the hospital. Patients, families can sometimes be very helpful to remind patients things, especially older patients or patients who are confused. Sometimes they may be overwhelmed and forget what we've told them. Dietary restrictions are a good thing to make sure everybody understands. For the most part, patient has to be NPO for 6 to 8 hours, like I mentioned before. So, really educating why that's important and reducing the risk of aspiration and possibly even surgery getting canceled. I've seen that happen before multiple times, where patients been planning on going to surgery and they ate anyway, because they were like, oh, well, they brought me my tray, so I just ate it. When really they probably knew that they shouldn't have been eating. There was an error that was made. The patient got a tray, they ate it. Their surgery is delayed a whole day, and they get really upset by that. So patients can participate in their care and advocate for themselves so that there is not a delay in their surgery. They should also know what it's going to be like after surgery as far as eating. A lot of times we want to ease them back into eating, since we're kind of on that subject. We don't want them to wake up and eat a big steak and potatoes. My husband, when he had surgery, he kept wanting a chili dog with mustard and onions, and I was like, no, you don't want a chili dog. And he was in like this, anesthetic state, but he kept arguing with me about it, and the poor man drank grape juice and then tossed his cookies. So there's no way that a chili dog would have been any good for him. So we want to start patients out slowly. Oftentimes, especially if it's an abdominal surgery or some kind of GI surgery, they may not be able to have anything to eat or drink yet for a period of time. And then once there's a return of bowel sounds, maybe some evidence of passing gas, then maybe we can start to introduce some things. They're not feeling nauseated anymore. But we advance that diet slowly, maybe start with clear liquids, and then maybe a full liquids, and then maybe a soft diet, and kind of amp it up a little bit. Now, a doctor may not put in each stage of an order. They might say advance is tolerated, and so the nurse can kind of drive that depending on the patient's response to the dietary intervention. So patient comes back from surgery, oftentimes like appendectomies usually happen really quick. Post-operative recovery takes place really quickly. Always tell them, let's start with water. Let's see how you do with that. If they come back like, I'm so hungry. And then if they do well with water, then maybe I'll give them a little bit, some crackers or something like that. And then just kind of progress it slowly. Other things to include in teaching is what to expect after they wake up. They might have tubes in place. They're going to have pain. We kind of talked about how to deal with pain. Nausea is very common in the postoperative period. So we need to let them know that they'll have medication available for them to help to control those symptoms. They might have a Foley catheter. Their throat might be dry and itchy. They might have a sore throat. That's pretty common because they do some, like in an airway, they want to protect the airway during surgery. We're going to ask them to cough and deep breathe. This would be a great time to have them demonstrate their ability to do this in the preoperative phase, so that we can kind of get that teaching going. What incisional pain is going to be going to be looking like, how to splint incisions. That might be something else we teach them about. Let's see, patient might have SCDs on or TED hose. Those can be kind of annoying to some people. What their IV situation is going to look like. So what it is they're going to expect to see when they wake up, and what it is that we're going to expect them to do when they wake up from surgery. Because it can be very scary if you've never had surgery, kind of waking up. It's a very disorienting feel. So we want to make sure we're giving them a heads up on what to expect there. It can take practice for the new nurse to really get a good understanding of what to educate a patient on what to expect. So if you don't know, read up on your surgeries as you move through your nursing education or your nursing career. Ask questions, observe other nurses do preoperative teaching, so that you can kind of integrate that into your own practice. But it does take a little bit of time there. Oh, what happened? I clicked on something I didn't expect. I don't think you guys saw that, but that's okay. Okay, so this, I'm not sure what I did there, but that was an NG tube. This is a Foley catheter. You guys know that. So some things a patient might see, we've got a JP drain. This is an incentive spirometer. These are all things that patient might see the post-operative period. These are SCDs. The patient also has TED hose on. There you can see those white stocking things there. Okay, so medications. Discussion question number 8 talks about, nope, that's dietary restrictions. We talked about that. So number 9, should a patient take their medication before surgery? Well, it just kind of depends. We really have to be careful about what medications we give to a patient during surgery. Part of that's going to be based on our assessment data that we contain, assessment data that we obtain. Some medications we don't want to give. We're really going to be looking at a provider's guidance for this, but we can definitely use our judgment. So, for example, I mentioned like antiplatelet medications. If your patient has an anticoagulant or an antiplatelet medication like Plavix or heparin or aspirin, and it's scheduled to be given, I would not give that. I would call the provider and I would say, hey, I'm going to go ahead and hold this. Do you mind? Because that's going to increase the risk for surgery, and those things should be discontinued before the patient even goes to surgery. It might vary in length, how long those medications need to be discontinued for. So for example, heparin, we can discontinue that like 6 to 8 hours before surgery. And aspirin, though, we need to discontinue about a week out. So some things to think about there. I mentioned beta blockers already, some of our cardiac medications we can give prior to surgery. But if we're not sure, we can always call and get guidance from the provider. Which medications would you like this patient to take before I send them down to you? Because they take this list of daily medicines. Others, we can sort of use our judgment and say, oh, they take a multivitamin every day. Well, I don't think they're going to die without a multivitamin before surgery. All right, so use your judgment, and if you're not sure, you always just ask. Some medications we might be ordered to give, like what you can see here, medications for anxiety, so like Valium or other benzodiazepines like Ativan. Those might be given prior to going down just to help relax and calm the patient. Antiemetics are provided sometimes before surgery to reduce the risk of postoperative nausea and vomiting. So things like ondansetron, also known as Zofran, patient might get those before even going down. Antibiotics, I mentioned that when we talked about allergies, how antibiotics might be given prior to reduce the risk of surgical site infection. Generally speaking, though, and when it comes to medications like scheduled home medications, a patient will probably take their cardiac meds, meds for hypertension, If they have a history of seizures, they'll probably take their seizure medications. And if they have any type of respiratory problem, we're probably good to give those. And we can give those with sips of water. So just because your patient's NPO, we don't have to say, oh, they can't have any of their meds because they're NPO. We can. They just are administered with sips of water. And again, just to reiterate, we can always follow up with the doctor if we're unsure. Other preparation that we might do for surgery, I don't know that I've ever done a bowel prep for an actual surgical case, but for endoscopy, of course, I've done bowel prep. Patient needs to have an IV insertion. Skin prep, I mentioned CHG, so that's something that we would do there as well. Let's see, I think we actually made it through the whole preoperative checklist. Let me see, I can exit. Screen sharing is shit. Okay, let me go back here, see if I can see you guys. Let me just start my video. I bet that'll work. Close this. Peekaboo, there we are. So that's pretty much the conclusion on preoperative assessment, preoperative nursing care. There really isn't much more to tell you. If you have questions regarding the discussion questions for preoperative care, let me know. I have asked you to fill this out and upload it as an assignment just so I can have an idea of how well you understood what I covered in this lecture. So if I feel like you haven't gotten something very well, I will let you know. But you get the points for answering the questions. So I mean, it's pretty cake there. I would take advantage of that if I were you. You do have to do it, so you might as well see how well you did and get some feedback from me if you need to. Other than that, that concludes our preoperative nursing care lecture. Reach out if you need me, and stay tuned for postoperative care. Very exciting. I gotta figure out how to stop recording. There it is. All right, you guys have a good day.